morning. We're going to go ahead and get started. It's a real privilege for me to introduce our guest speaker today, Dr. Kansara, who's part of the internal medicine department here, has been on staff for the last 3 years, and he's going to give us an update on diabetes and the heart, with focus in on the newer medications and the potential implications from a cardiovascular perspective, so certainly pertinent to our group here. Dr. Kansara completed his medical school training in India and his internal medicine residency and fellowship in sunny downtown State Medical Center. He also complemented his training in internal medicine and endocrinology fellowship with acquiring a master's of public health in Brooklyn and New York. He's been dedicated to continued education for the past 5 years with case-based learning projects with house staff, and has a real interest in the intersection of endocrinology with a diabetes focus and cardiovascular disease overlap. So he's well positioned to give us an update. Appreciate you taking the time, Dr. Kansara, to be here with us here today. We look forward to your talk.
Thank you. Good morning, everybody. I was asked to do this talk, and it doesn't surprise me. I was in the elevator with one of the pulmonologists a few days ago, and he asked me about some weight loss medications, and I spit out a couple of names, the newer ones, and surprisingly enough, he did not know what they were, and my apologies to him for making him feel old, since these are very relatively new drugs. A lot has happened lately in terms of diabetes medications that have come out in the last 10 years. Several of these medications are very new. Little is known about their cardiovascular effects. Yes, they have been good medications to help achieve diabetes control, better diabetes control, but we don't know much about how do they affect the heart in the longer run. So I have tried to summarize here 2 things. One, is it important to have better diabetes control? And 2, and how do we best do that, keeping in mind, since all of the medications now are required to have cardiovascular safety outcome data. To address the first question, I'll start with the very well-known, the DCCT EDIC study, which was done especially in type 1 diabetic patients, wherein they compared conventional therapy, which was back in those days, 1 or 2 insulin injections, and they measured either urine glucose or capillary glucose, whereas intensive therapy was a multiple daily injection versus an insulin pump. The primary prevention was to see if there was any retinopathy, how did it affect retinopathy, and how did it affect urinary albumin excursion. It was about a little over 5 years. The study ended in 1993 because they saw some promising results there. The DCCT was the intervention study, and they did a follow-up study after for a 10-year period, which is the EDIC cohort. Actually, the EDIC goes on, and they monitor EDIC cohort over time. These are some of the parameters that they looked at to assess for renal function, retinopathy, neuropathy exams, and even some cardiovascular data, which was what they collected. This classic slide from this paper. As we see, the top part shows conventional treatment, wherein the A1C was 9.1%, and the bottom here shows a mean A1C of 7.2%. So they treated them for about 10 years. And there was a training period. So those who were in the conventional group, they were trained how to manage their diabetes intensively. And after that, in the follow-up period, they noted that the A1Cs were similar in both the groups. What did they study here? What did they find from this intervention? They noted that with the DCCT, they had noted that there was reduction in the retinopathy, and also there was a reduction in the progression of retinopathy. So did the cases, so was it seen with both micro and macroalbuminuria, and with neuropathy as well. With the EDIC, and they have data up until 2011, they noted similar findings right there. When they combined both DCCT and EDIC, they noticed similar events, and even the cardiovascular events were lower in the follow-up study. This pulls up information. This basically shows the same thing, that over time, the complications in the intervention arm were much lower as compared to the control arm, and about the end of DCCT and the EDIC combined together. Now in type 2 diabetics, the UKPDS study, primarily done in the United Kingdom. They had about little less than 4,000 patients where they randomized them to either sulfonylurea and insulin combination therapy versus conventional therapy, which was diet. They even added metformin to patients who were obese. And the primary outcome they were looking at was any diabetes-related event or death, and that they had a median follow-up for about 10 years. Here, they saw that actually I can come back to this one. What did they find here? The dark circles is the conventional arm, and the blank circles are the intensive therapy. They noted the fasting plasma glucoses were lower in the intensive therapy. They also noted that the A1C was lower, and the gap persisted over time. And this was about a 10 to 15 year follow-up period they have there. Interestingly, and not surprisingly, they did notice that there was weight gain in the intensive treatment group, and also the plasma insulin levels were higher in the intensive treatment group. This slide shows how they have compared different intensive treatment groups, and primarily with the different sulfonylureas. There's not much change. They have a similar trend. This is compared to the conventional arm, and they have a similar pattern there. Now, with this particular slide, what does that show? There was not much of a significant difference in the diabetes-related deaths, as we see here. That was more or less non-significant. But when it came to diabetes-related endpoints, there was a difference in the conventional versus the intensive arm. The intensive arm did see some benefit there. When they split up the different groups, not much of a significance. Here, they're looking at microvascular endpoints and myocardial infarction. Between the two groups, this is what showed there was a difference between the two. The p-values were noted to be significant, suggesting that intensive treatment did have a positive outcome on the microvascular complications and with myocardial infarction, and not much in terms of stroke. Again, the surrogate clinical endpoints between the conventional and the intensive arm, they were not really different. When they separated them with different sulfonylurea medications, they were not really different either. With the 10-year follow-up study, so the first study showed maybe some improvement with microvascular complications and with myocardial infarction, but no major macrovascular benefits were noted. With the 10-year UKPDS study, about half of the patients, they had complete post-trial monitoring, and this was a 10-year follow-up study. In this study, what they noted was at the end of 10 years, the A1C levels, the body weight were similar. In fact, the body weight was somewhat higher in the sulfonylurea and the insulin group, somewhat lower with the metformin group, which is in green. The A1Cs remained down. Here, when you compare the two groups, the sulfonylurea and the metformin group, a difficult table here. When you compare in the intensive arm, which had sulfonylureas and insulin, the number of events with clinical outcomes were higher as compared to the conventional therapy, but they were noted to be lower with the metformin group as compared to the conventional therapy, suggesting that metformin potentially has a positive effect or benefit on cardiovascular outcomes. Similar findings in this graph. The red one is the baseline, and this is something which they followed up over time. On the left is sulfonylurea insulin. On the right is metformin. What do we find here? With any diabetes-related endpoints, metformin had a positive finding there. It was well beneath. There was a relative risk reduction noted there. So was the case with myocardial infarction. But what they did not see much of a difference with macrovascular disease, whereas the sulfonylurea and the insulin group did show a benefit there. And any diabetes and death from any cause showed improved mortality with metformin. This is showing similar information. Again, sulfonylurea, insulin here, metformin on the right, and with same thing. These are for myocardial infarction and any diabetes-related endpoints. A couple of other studies, Advance, wherein they treated intensively patients with glyclazide, which is a sulfonylurea. Their median follow-up was about 5 years. And they had patients who were older than 54 years of age, and they had either some kind of major macro or microvascular complications or any risk factors for neovascular disease. Upon follow-up for 5 years, they noted that the A1Cs were significantly different in the intensive arm versus the sulfonylurea arm, both the A1C and fasting glucose. Here's the difference that comes into the picture. When it came to major micro and macrovascular endpoints, there was a benefit in the intensive control arm, but there was no benefit with the major macrovascular events. But macrovascular events were noted to have statistical significance in the intensive control group. Again, this shows the hazard ratios. They were, again, in the microvascular endpoints, had a positive outcome, as it's towards the left of unity, and it's a microalbuminuria. Some improvement in microalbuminuria with the intensive control group. And not much, and this talks about the combined major and micro and macrovascular complications with not much of a difference there. So how did they summarize this? That yes, they did notice an improvement in both micro and macrovascular complications, but that benefit was largely because of an improvement in microvascular issues. So this still doesn't tell us much about macrovascular complications of how does that affect, how does that help. The VADT trial that include metformin and rosiglitazone, and those who were overweight patients, overweight patients were treated with metformin, and BMI less than 27 were treated with glimepiride. They used intensive arm was maximal doses, and conventional was about half of the maximal doses, and they followed them up for about 5.5 years. They did notice the A1C, as we see, the A1C has been noted to be improved in the intensive arm as compared to the control group. Now, here in this slide, what it shows that this does not show any significance between the intensive and the control arm, no matter in terms of the primary or the secondary outcomes. So that leaves it no effect, basically. And of course, the intensive group had some hypoglycemic episodes, which were more in the intensive arm. Macrovascular outcomes were not really significant, as we see out here. Accord. In type 2 diabetics, over 10,000 patients they had, and cardiovascular disease, they looked for anatomical evidence of any atherosclerosis, albuminuria, or left ventricular hypertrophy, or if they had any multiple risk factors for cardiovascular disease. Intensive arm was treated up to A1C of less than 6, whereas the conventional was around 7 to 7.9. The A1Cs, as we see, were maintained in the intensive arm. They did maintain the separation. But what they noted here was, in the primary and the secondary outcomes, they noted an increased incidence of death in the intensive arm as compared to the control group, and that was statistically significant. This prompted the investigators to halt the study prematurely, as they noted an increased incidence of coronary events, or death primarily. This splits up right here right there. The slide up here, it shows with the intensive arm, there was a large number of coronary cerebrovascular events. This led to the recent guidelines or recommendations, both by the ADA and the ACE, that how do we go about treating for patients to individualize goals, basically. So for A1C of less than 6.5% in patients without any serious illness or any other risk factors for hypoglycemia, and those with an A1C of more than 6.5, if they have any concurrent issues or comorbidities, or if they're at high risk for hyperglycemia. I like this better for one of the reasons it shows about, based upon these factors, how strict would one consider treatment algorithm for a diabetic patient. If they had comorbidities, if they had a longer life expectancy, yes, I would tend to be more aggressive. If they had a newer onset of diabetes, it would be more of an aggressive treatment plan. And again, if there were any other associated hypoglycemia or other outcomes. This is some CDC statistics around 2010, 2012. the number of adults, or the percentage of population using diabetes medications, about 14% is insulin, and about 57% is oral medications only. And there's a good chunk, about 14%, are using neither of the two groups. How do we manage diabetes? Simple differentiation with insulin or non-insulin options. When we look at insulin, it has been around since 1922. It has been the default treatment plan for patients with type 1 diabetes. Insulin was, hyperinsulinemia is associated with atheroma formation and potential cardiovascular risk with those. This trial was recent, in about 2005 is when they did this trial. They come up with this trial. This was sponsored by Sanofi, which is the maker of Lantus, a very routinely used basal insulin, glargine. They had about 12,500 patients in here with a mean age of around 64 years old. The patients should have cardiovascular risk factors with either impaired fasting glucose, impaired glucose tolerance, or type 2 diabetes. They were followed up for little over 6 years. And they looked at either death or hospitalization or revascularization procedure with cardiovascular outcomes. They noted there was no statistical significance except for one aspect which they noted was that there was some improvement in the new onset new angina in patients treated with basal insulin in this study. Otherwise, there was no significant differences. They did not notice any other harmful events. So with the severe hypoglycemia, yes, it was a little more notable in the intensive treatment arm as compared to the standard therapy group. Several other non-insulin agents for type 2 diabetes that we have. Alpha-glucosidase inhibitors. How do they work? They impair carbohydrate absorption. Amylin analogs that decrease glucagon secretion. They slow the gastric emptying. Biguanides metformin, which is one of the very old medications that we have. It decreases hepatic gluconeogenesis and also can increase glucose uptake in the muscles. Bile acid sequestrants have been proposed. DPP-4 inhibitors, a relatively new class of medications. Glenides, they work like sulphonylureas. Dopamine agonists, not strong anti-diabetic medication. Other agents, GLP-1 receptor agonists, how do they work? Is they increase glucose-dependent insulin secretion, and they decrease glucagon secretion, and also slow gastric emptying. SGLT2 inhibitors, the newest kids on the block, the way in which they work is they release the excess glucose in the urine. And TZDs, they increase, basically insulin sensitizers, they increase glucose uptake in the peripheral tissues and muscles and the fat, and also can decrease hepatic gluconeogenesis. Now, metformin, it was first synthesized in 1929. The first trial was around 1957. The mechanism of action I have up right there. This is again from the UKPDS 10-year study. How does metformin have a beneficial effect on the cardiovascular outcomes? This is with the myocardial infarction had an improvement, and death from any diabetes-related endpoint, and death were significantly lower in the intensive treatment group with metformin as compared to sulphonylureas and insulin. This study, again, highlights the importance of metformin, and they measured carotid intima media thickness using ultrasound in these patients, and it was a Japanese study back in 1998. Patients were enrolled from May to June of 1998. They had to have type 2 diabetes, and they were treated either with sulphonylureas, 2 sulphonylureas, and glibenclamide and metformin combination. And they did carotid artery scans before and after. What do we notice here? The average intima media thickness with the glibenclamide group, before and after, it increased. With the glyclazide group, it stayed the same, or a relatively smaller increase as compared to just in the glibenclamide group. When compared with both the metformin, when you had both the metformin and the glyclazide, combination of two, there was even a slower progression of carotid intima media thickness. And this shows about how fast did they progress. Again, they progress suppression was much lower in the glibenclamide, the glyclazide, and the combination. Combination group was the slowest as compared to the other three. So this does indicate that metformin does have a potential benefit in cardiovascular outcomes. Another study for metformin, Canadian-based study, wherein they identified new oral anti-diabetic drug users in Alberta. And this is a unique population in the sense that about 91% of population has health coverage, and they can track prescription claims and how they have used. If patients have not used a medication in the last year, they've considered them as new use. About 12,000 patients, and they were followed for about 5 years. But the minimum follow-up was about 3 years. Similar characteristics, sulfonylurea group had about 3,000 patients, metformin group had about 1,100 patients, and the combination was around a little less than 4,700 patients. In this group, when they adjusted the odds ratio for multivariate logistic regression models, all-cause deaths with metformin were much lower, and about 0.6 was the odds ratio, and also with the cardiovascular deaths was significantly lower. And even when metformin was used in combination with sulfonylurea, they produced similar results. Crude mortality rates, again, in patients, dark black solid is only sulfonylureas. Metformin had a lower mortality rate, and again, the combination had a lower mortality rate. And we see a similar effect with the cardiovascular data, cardiovascular events. This another population-based study in the United States looking at Medicare population, about 16,000 patients in 80, and they looked at these data in two groups, 1998 to 1999, and in 2000 and 2001. They used ICD-9 diagnosis codes of heart failure and with patients with diabetes, or they were discharged home on diabetes medications. Primary outcome, death due to any cause, and secondary outcome was readmission time for any cause of heart failure. In this group, what did they notice that? And they looked at patients who were on insulin sensitizers, two of them largely being metformin and TZDs. In TZDs, they noted about a 30% mortality. With metformin, they noted about little less than 25% mortality. And in groups which had no insulin sensitizer use, it was about 36%. Similarly, the hazard ratios were beneficial with the TZD and the metformin category. Neither of these cross unity as compared to insulin and sulfonylureas, which were not significant. Basically shows the same thing in patients who were on an insulin sensitizer. They had the Kaplan-Meier curves were noted to be higher mortality over time as compared to with insulin sensitizer use with TZD. Similarly with metformin. Yes.
Do you mind speaking up a little bit to project to the back?
Sure. Okay. Is this any better? Okay, sorry. The VA database looked at patients with ambulatory care VA patients back for about 2 years, from 2000 to 2002. The primary outcome was time to death in over a 2-year period, and secondary outcome was hospitalization or from any cause. In the metformin group, they noted that there was improved survival as compared to patients who were not on metformin. Again, this is a retrospective data. Similarly, in patients who had, this was hazard ratios which were noted to be beneficial in patients who had an improved GFR worsened GFR of less than 60, and those who were obese. Actually, this is a study from Baylor, with colleagues from Baylor, and this was done at the DeBakey VA, is where they worked at. How does metformin work, or how do they propose metformin could have such potential health benefits, or in terms of cardiovascular data? Metformin works through AMP kinase. With the AMP kinase, they've noted there could be some improvement with fatty acid, increased fatty acid oxidation, which can improve with lipid parameters, and that results in improved lipid profile. Hyperglycemia through the DAG-PKC pathway, the protein kinase C activation, can increase oxidative stress. metformin, and in some studies, liraglutide, which is one of the GLP-1s that I'll talk about a little later, they have shown that has minimized oxidative stress in such patients. With increased ADP synthesis, there is increased glucose uptake that that improves energy balance in ischemic conditions. In the PK, the phosphatidylinositol pathway, they have noted with the MPTP opening and decrease in myocardial infarction and size. They've noted an improvement with that as well. Another postulated mechanism with plasminogen activator inhibitor 1. It decreases levels of those, which minimizes hypercoagulability and also increases fibrinolysis. And that can improve peripheral circulation. Sulphonylureas. Sulphonylureas, they have had mixed results over time with studies. It first started in the 1970s with the UGDP study, wherein they noted increased incidence of cardiovascular deaths with tolbutamide. And over time, there have been more studies to see how that has benefited patients or not benefited patients, if at all. This study, it's an Italian study, wherein in the way in which they carried out this study to see the effect of sulphonylureas or insulin in ischemia-induced myocardial dysfunction in patients with type 2 diabetes. So they had about 19 patients, and they either had to have some form of stable angina or coronary vessel obstruction on angiography. Patients were randomized either to insulin or glibenclamide for 12 weeks, and then they crossed over. And how did they measure parameters? They measured echocardiogram at rest and after dipyridamole infusion. This slide up here shows left ventricular ejection fraction. This area here, it's the baseline and on glibenclamide, and this is after dipyridamole infusion. As we see, there's a uniform trend, or largely uniform trend, towards a reduction in the ejection fraction with dipyridamole, with a p-value that was statistically significant. When patients were on insulin, these factors did not really change much. With glibenclamide, they looked at wall motion score index. And you probably would know this better than I do, that the lower the score is, the better towards normal function. With glibenclamide, they noted that the scores increased as compared to with insulin, wherein the scores were relatively flat. That was not significant. And the p-values were noted to be significant right up here. This again looked at patients, compared 3 groups of patients on rosiglitazone, metformin, or glyburide. They had about 43,000 patients, 4,300 patients who underwent randomization. And in this study up here, they noted that this study was not designed to look at cardiovascular outcomes. However, they did notice that there was no significant changes in terms of deaths and hospitalization between the 3 groups, either with metformin or rosiglitazone or sulphonylureas. They had similar hospitalization or heart failure events. Now, this is a Danish cohort wherein they looked at mortality and cardiovascular risk in patients who were started on medications, sulphonylureas basically, when they compared that with metformin over time. They looked at the index prescription when the first time the prescription was used or filled at the pharmacies of any glucose-lowering agent, primarily sulphonylureas, and they compared that with metformin. They followed them up to 9 years, with the median follow-up was about 3.3 years. They identified events based on ICD-10 and ICD-8 diagnostic codes. As we see up here in this study, metformin is considered as compared to metformin. They noted with glimepiride, glibenclamide, tolbutamide, and glipizide, they noted that there was increased myocardial infarction, even total deaths basically, in patients who had no previous MI as compared to patients who had previous MI. Cardiovascular death, again, was similarly noted to be higher. And MI, stroke, and cardiovascular death, again, were noted to be higher, except for two medications, the glyclazide and the repaglinide. These groups did not have any increased mortality as compared to, and it's similar results in patients whether they had previous MI or they did not have previous MI. Again, this looks at individual agents, and here, similar, the blue and the red, they were with the trend with the lowest as synonymous with metformin in both of the two groups. So with these, what do we get from these studies is that, yes, the older tolbutamide was associated with some cardiovascular risk or events, increased incidence of cardiovascular events with them. And however, with some of the population studies, they have shown that there has been some or not much benefit. Some of them have been, it's basically mixed results that we are getting. Some have positive outcomes, some of them were neutral. Looking at TZDs, pioglitazone, I'm missing a T there. This was one of the studies done with the proactive study looking at secondary prevention of macrovascular events in patients with type 2 diabetes and were randomized to pioglitazone. They had, this was an extensive study that was conducted in Europe, and they looked at patients for about a year, enrolled in the study for about the enrollment period was for a year. They followed them up for about a little less than 3 years, and they had to have extensive macrovascular disease. And they randomized patients either to pioglitazone versus placebo. What did they see here? The hazard ratio was lower in the pioglitazone group. They had lesser events as compared to the placebo. And the p-value was not statistically significant. The confidence interval crossed unity. Similarly, looking at the proportion of events, we noted a similar trend with that. However, they did notice that the patients' overall survival, the patients had a higher, lesser events with, here. The proportion of events was much lower in the pioglitazone as compared to the placebo group. They looked at primary endpoints. They were not really significant between the pioglitazone and the placebo group, and when they looked at non-fatal MI, stroke, leg amputation, and acute coronary syndrome with coronary revascularization, and also leg revascularization. The total number of events in the pioglitazone group were lower as compared to the placebo group, but they did not really achieve any statistical significance. Medication use. Patients who were in the pioglitazone group, they required less insulin as compared to placebo, which required larger number of patients with insulin. Metformin use went up in the placebo group as compared to the pioglitazone group. Sulphonylureas use was much lower here, similarly here, but this could primarily be because a lot of patients were started on insulin. And when they looked at other numbers like statins and fibrates, they were similar. How did the lab values improve? In the pioglitazone group, the A1C did get better to a larger degree as compared to the placebo group. Triglycerides improved, wherein they went up in the placebo group. The LDL cholesterol went up. The HDL improved, and so and the microalbuminuria, which was basically non-significant between the two groups. This was a meta-analysis which they did. Looked at several trials, and a large part of the trial was the proactive study, which had over 5,000 patients, which I just talked to you about. And they looked at data from, and that's meta-analysis, which they looked at. They had about 19 studies and looked at 16,000 plus patients in this analysis. What did they notice here? They had, and the slide doesn't come out too well, in the death, myocardial infarction, or stroke. They noticed the incidences were lower in the intensive group or with the pioglitazone group as compared to the comparators. And what did they notice here? This slide shows heart failure. The heart failure incidences were higher in the pioglitazone group as compared to the other agents. Similarly, they noted basically shows the same thing in the death, myocardial infarction, or the stroke, as compared to the serious heart failure, which had a trend towards more than unity. And this is one of the recent trials which came out in the New England Journal in February, which talks about, they looked at patients with insulin resistance and who had stroke in the past or a recent stroke in the last 6 months. And they worked on treating insulin resistance with pioglitazone. None of these patients had diabetes. However, they looked for patients who had some evidence of insulin resistance, and they picked up these patients, calculating the HOMA-IR, which is the homeostatic model assessment to assess for insulin resistance. The parameter more than 3 was noted to be patients with insulin resistance in normal subset of patients. And they looked at what were the events they looked at were fatal or non-fatal stroke or MI. It was a double-blind placebo-controlled study, about less than 4,000 patients, and for about 8 years. What did they notice here? In the pioglitazone group, they had less incidences of stroke or myocardial infarction as compared to the placebo. And they noted that there was less progression to diabetes in the pioglitazone group as compared to the placebo group. The deaths from any cause, they were not significant. This shows, again, the event survival, which is more with pioglitazone group. When they did the subgroup analysis, they had noted better outcomes with patients who were younger, patients who were women, patients who were white, of non-Hispanic background, those who had a lower BMI, those who were either normal or overweight BMI, those who did not have coronary artery disease, but patients with hypertension, those who were less insulin resistant on the scale, and those who had lower A1Cs. And similarly with higher fasting glucoses and HDL levels had better outcomes. In terms of side effects, there was no significant difference in the bladder cancer. Pioglitazone was, you could say, temporarily defamed because of its potential association with bladder cancer. In this analysis, which they see, there were 12 patients in the pioglitazone group and about 8 patients in the placebo group who had bladder cancer. When they did further analysis, they noted 4 patients and 2 patients respectively. There was an increased incidence of bone fractures in the pioglitazone group, increased incidence of heart failure, and they had significant weight gain. About 11.4% of patients had weight gain of more than 13 kilograms. Edema was increased and shortness of breath were increased, and there was a higher portion of patients a lower percentage of patients with increase in the ALT. Now, this all started, the need to have cardiovascular outcome data for diabetes medications all started with the rosiglitazone controversy, wherein in that particular study they noted patients with rosiglitazone, in a meta-analysis, this was published in 2007, and I don't have that slide up here, they noted increased deaths in those patients. That prompted the FDA and the European Medical Agency to have newer diabetes medications to have outcomes data. The newest group of medications, the incretin mimetics and the SGLT2 inhibitors, they've been around for about 10 years or less. And recently, some of the data are coming out in terms of how do they affect cardiovascular outcomes. 2 categories of agents here, DPP-4 inhibitors and GLP-1s. DPP-4 inhibitors, DPP-4 is an enzyme which degrades the GLP-1. DPP-4 inhibitors, as the name suggests, would prevent that degradation. GLP-1s are intestinal polypeptides, and they have favorable outcomes on glycemic parameters. They also decrease glucagon secretion. They decrease or they delay gastric emptying and improve satiety. All of these factors have made them favorable for use in patients with diabetes because of their, and they've resulted in weight loss, which attracts many endocrinologists or primary care physicians to consider these medications their treatment plan. DPP-4 inhibitors, again, most of these studies are industry-sponsored studies. Their respective pharmaceutical company conducted these studies for their agents. The SAVOR trial published in New England Journal in October 2013, and that looked at saxagliptin. This had about 16,000 patients, and they were followed up for a median period of 2 years. And they looked at cardiovascular death, non-fatal MI, or ischemic stroke. What did they find here? They noted that the primary and the secondary endpoints were not different between the two groups. They were unchanged. Patients did have lower A1Cs. They did have some improvement in their glycemic control, but there was no significant difference in the events noted between the two groups. As we see from the table on the right side, the p-values are non-significant from any of these parameters that they looked at. Death from any cause, death from cardiovascular causes, myocardial infarction, or ischemic stroke. Except for one thing which they noted here was hospitalization for heart failure. They noted increased heart failure hospitalization in this subset of patients. Why? It's still not very clear. They speculate that this may have been the way in which the information may have been collected. So that doesn't explain a whole lot much there. In the same issue of the New England Journal, another study came out with allogliptin as a DPP-4 inhibitor, which was studied. They had about over 5,000 patients. They were randomized either to allogliptin or placebo, and they followed them up for a median period of about 18 months. They did notice that the A1Cs did improve. There was a difference between the two groups, with the A1Cs, with the allogliptin group having lower A1Cs. However, they did not notice any significant differences in all of the outcomes of the primary endpoint, and even when they looked at the composite endpoints, they were all similar between the two groups. When they looked at the major safety endpoints, practically no difference between the two groups, be it death from any causes or cardiovascular causes. However, they did not look at heart failure hospitalization. In patients who are on DPP-4 inhibitors, the BNP may have to be potentially cautiously interpreted because the BNP does serve as a substrate for some of these DPP inhibitors. The more recent group of medications, the GLP-1s, these are injectable medications. Newer formulations are once-a-week preparations. Positive findings associated with these agents is weight loss, which entices many people to consider these for their patients. This was a database study, a LifeLink database. LifeLink database has looked at medical and pharmaceutical insurance claims from 2005 to 2009, and patients who have had type 2 diabetes and that they were started on a new agent. They looked at EXENATIDE, which is the first GLP-1 approved in both the United States and Europe as compared to non-EXENATIDE group. And they looked at incident outcomes with similar outcomes with MI, ischemic stroke, or coronary revascularization. What did they find here? They noted that in the patients with the combination therapy, or with the comorbidities, patients who were in the EXENATIDE group, they had more severe disease. They had higher indicators of diabetic retinopathy. They had higher indications of cardiovascular disease. There was more hyperlipidemia. There was more hypertension. There was more ischemic heart disease in the subset of patients. They also had, because they had these conditions, they were also largely on multiple medications, multiple diabetes medications, and multiple cardiovascular medications that included beta blockers, ACE inhibitors, statins. And in this group, they noted that patients who were on exenatide, they had a favorable hazard ratio, which was very significantly further away from unity, showing a favorable indication about these medications. In summary, the exenatide group was more likely to have other comorbid conditions. They were less likely to have a cardiovascular disease event, and they had lower rate of hospitalization, and also with all-cause hospitalization. These are some of the ongoing trials for patients with GLP-1 agonists. And the results are anticipated any time, except for the first one, the LEADER trial. It was just in March, this month, about 5 days ago, Novo Nordisk announced that liraglutide is associated with significant cardiovascular benefits. They haven't released the data yet, likely at the ADA meeting in June this year, when they will release more information on liraglutide. Liraglutide is a once daily preparation of the GLP-1s. Now, how do GLP-1s affect heart failure? They looked at this study in dogs, wherein they infused recombinant GLP-1 in dogs were induced dilated cardiomyopathy, and that they noted that GLP-1 increases myocardial glucose uptake and improves left ventricular performance. In patients who've already had an acute myocardial infarction, they looked at how did that affect the left ventricular ejection fraction after successful reperfusion. So the patients, they had to present within 6 hours of symptom onset. Their CLIP classification was a higher classification between 2 to 4. They had to have an EF less than 40% when they underwent primary angioplasty. They did an echo within 2 hours. And 10 patients received GLP-1 infusion for 72 hours. And they measured echo ejection fraction 6 to 12 hours after infusion. The patient demographics in between the two groups, they had 10 patients in the GLP-1 group and 11 patients in the control group, which did not receive the GLP infusion for 72-hour period. The patient characteristics were more or less similar. Here, when we look at the left ventricular ejection fraction, this looks at control groups, GLP-1s, and this is in the control groups. When they were similar before they received the GLP-1 infusion. However, when they received the GLP-1 infusion, there was an improvement in ejection fraction in this subset of patients. When they looked at wall motion score indices, there was an improvement in the post-GLP treatment, basically, and this is where they noted that the ejection fractions went up in the GLP-1 group as compared to the control group, and similarly with the wall motion indices, which improved with the GLP-1 infusion. Again, now they looked at patients who had diabetes and the patients who did not have diabetes, patients who had anterior MI, patients who had non-anterior MI. Those with diabetes, yes, the ejection fraction did improve. The wall motion score indices improved both regional and global. Similar parameters which were noted in non-diabetic patients as well. The anterior MI, again, the ejection fraction that improved in the anterior MI group, similarly noted in, so basically they noted benefit irrespective of the location of the MI and irrespective of the patients were diabetic or they were not diabetic. Other data which may not be significant in such a small population, they noted that in hospital mortality was low with GLP-1s, cardiovascular mortality was none in these group of patients, the hospital length of stay was lower, and CCU length of stay was lower in these patients. How about with patients who are undergoing CABG surgery? So here they looked at patients who were going elective CABG surgery. Their ejection fraction had to be over 35%, And this was the classic randomized double-blinded placebo-controlled study, wherein they infused GLP-1 at 5 nanograms per kilograms per minute, and they had about 12 patients in each group. They started the infusion 12 hours before CABG, and they continued it until about 48 hours after the CABG was done. And they also looked at effect of GLP-1 on glycemic control. That was their primary outcome to look at. How do the GLP-1s affect glycemic control? And they, of course, they measured some of these other samples with glucose, C-peptide, insulin levels, non-ester of fatty acids. And they also, while they were patients who were in the ICU, they measured their cardiac indices, cardiac output, cardiac index, mean arterial pressure, and pulmonary artery pressure, and the heart rate. During the infusion, they noted that their glucose levels were improved in the GLP-1 group as compared to the control group. And after that, they were more or less similar. When they measured GLP-1 levels, they did go up in the patients who had who were given the GLP-1 infusion. This is in the control group, wherein they received saline infusion. What did they notice here? So about 48 hours after patients who had CABG, they had an increased GLP-1 levels. This suggested this was in response to endogenous GLP-1 production in patients when they were started on diet after their CABG surgeries. There were some similarities in between the non-esterified fatty acids. The glucagon levels were lower with the GLP-1 group. Insulin levels were somewhat lower, but they were similar at the end of it by discharge. And the C-peptide levels were higher in the GLP-1 group. No significant changes were noted much in terms of the cardiac indices as they measured in the between the two groups. However, so they did not notice any significant differences between the two groups. What did they find? That patients who were on GLP infusion had 2 to 4 times lower inotrope, vasopressor, and vasodilator requirement. The control group required pharmacologic and mechanical support to increase their cardiac output. 2 patients in the control group required amiodarone to control their atrial arrhythmias. And there was a high requirement for insulin infusion to maintain euglycemia. A couple of others. This looks at intravenous GLP-1 EXENATIDE in patients with heart failure. What did they notice here? When they randomized patients to either receive GLP-1 and saline, they noted that patients with the GLP-1 versus placebo, the cardiac indices, they were 1 hour. This was a 6-hour study. So they infused GLP-1 for 6 hours. They were within 1 hour, they were higher in the GLP-1, but lower in the placebo group. Same thing with the pulmonary capillary wedge pressure. Those parameters had improved during the GLP-1 infusion as compared to a placebo group. GLP-1, what could explain the reason the GLP-1s have some favorable outcomes on cardiovascular data? GLP-1s, as we see from this table, in humans, which I've highlighted there, they present in several tissues: in the heart, lungs, pancreas, stomach, intestines, kidneys, breast, and endothelial cells. They have favorable effects on the blood pressure. These studies have noted that some of these patients had an improvement in, not all studies had an improvement in blood pressure. Blood pressure results have been mixed. In rats treated with GLP-1s, they have noted that systolic blood pressure, diastolic blood pressure, and heart rate have increased. How could that affect the blood pressure? There have been some effects on the vascular tone. How does that play a role? It's proposed that maybe GLP-1 activation affects the vagus nerve. And after bilateral vagotomy, GLP-1 infusion did not affect blood pressure or heart rate. This slide talks about the potential mechanism of the GLP-1. It affects on the brain in the area postrema, wherein that can inhibit the vagus nerve and can have decreased effects on the tone of the blood vessels. They can have direct effects on the kidneys, wherein they may have some degree of sodium retention, which can cause some blood pressure elevations. With potential effects on the heart, there may be some direct effects, but not much is known about them quite yet. And the other effects through pancreas and beta cell with decreased glucagon secretion, with weight loss, there are some potential mechanisms associated with that. These looked at various studies of the GLP-1 on the systolic blood pressure. The vertical bar do not indicate that they have elevated blood pressures. Some studies, like these up here, were not significant from placebo, were not statistically significant from placebo. Some studies here have noted an elevation in the blood pressure. What are the other effects that can potentially help? GLP-1s can reduce parameters like the CRP, C-reactive protein, and the PAI. It has, as we saw before, in rat models, I think I have this coming up now. The infarct size was reduced by about 40 to 50% in rat models, basically. Enhanced glucose uptake was noted, and increased insulin levels were noted, and they have an effect on the left ventricular function as well. This study up here looked at EXENATIDE, and that it reduces reperfusion injury in patients who have an ST elevation MI. They noted that with the GLP-1 infusion, the placebo is the solid line. These agents had lower infarct size and in the infarct area. So they had improved outcomes with GLP-1 infusion. The salvage index was greater with EXENATIDE, and the infarct size was smaller with the EXENATIDE group. And that was the case either if it was an anterior infarct or it was a non-anterior infarct. Effects on QT prolongation. There was a weak positive association in one of the studies in which the FDA asked for the clarification on the matter. When the duration 1 trial, they did not show any correlation between EXENATIDE and the QTc interval. And similar results were noted with liraglutide. GLP-1, they have noted on patients with body weight, they have been significantly decrease in body weight has been much higher in patients on GLP-1 when compared with placebo. The second study here, these patients were not diabetic, but they were obese patients. Lipid parameters. Not clear information. EXENATIDE can decrease triglycerides and can also with total and LDL cholesterol levels, but can also increase HDL cholesterol levels. GLP-1 can potentially can reduce chylomicron formation after a high-fat diet. SGLT2 inhibitors. This is the EMPIRE-X study, came out in November of 2015. Dump out excess glucose in the urine, and which has been associated with weight loss, side effect, potentially some genital infections. What did they notice here? This study, however, did notice some beneficial or significant impact on the cardiovascular outcomes. When they looked at primary outcome, which was non-fatal MI, death, or stroke, it was less with empagliflozin. When they looked at death from all cardiovascular causes, was again lower. Hospitalization for heart failure was lower, and death from any cause was also noted to be lower. The A1C levels were noted to be maintained. Differences were maintained over time. And there were 2 doses of empagliflozin which they used in the study. When they looked at the primary and the secondary outcomes, they did notice that it was for non-inferiority, it was clinically significant, statistically significant, and death from any cause was also noted to be better. The adverse events were not really a whole lot different to talk about. I'll talk about this one slide briefly. Potential mechanisms that could elicit why SGLT2 inhibitors can have positive outcomes on the heart. One, with glucose, they lower glucose and hence can potentially lower insulin levels. They are also noted to have an effect on the arterial stiffness and then thus can also lower blood pressure. They have noted to be associated with decreased microalbuminuria, lower uric acid levels. Similar data like with metformin and GLP-1s, they are proposed that they may have some beneficial effect in reducing oxidative stress. With decreased weight gain or weight loss, can also potentially implicate why did the study have positive outcomes. So basically, to summarize, of all these several groups of medications, with metformin, there has been some positive outcomes. If not, they have been neutral, if not negative outcomes. GLP-1s have been proposed to have favorable outcomes. The liraglutide study, which when we have more details in June, that can shed some more light in that matter. With SGLT2 inhibitors, with one study that I pointed out, there have been some favorable outcomes with that study. DPP-4 inhibitors, soft evidence, but potentially some mixed results noted there. With TZDs, TZDs have had favorable outcomes. The side effect or one concerning effect with TZDs is possibly an increased hospitalization for heart failure. However, they have noted an improved mortality with patients who are on TZD, similar like metformin. Sulfonylurea and the meglitinides, basically insulin secretagogues, they have the older sulfonylureas are potentially associated with higher mortality. Why? Because they may also potentially act through the sulfonylurea receptor on the cardiac myocytes, which could explain that association. These other agents are not very significant anti-diabetic medications, and insulin has had neutral outcomes so far. This shows about some A1C effects on these patients, but I think, yeah, with that, I think I'll end the talk. Yeah. Thank you.
So Dr. Kansara, certainly a lot of information about diabetes and the newer agents. So certainly appreciate the broad overview. Certainly a difficult topic in the context of the breadth of information. Let's jump in and see if any questions from the audience. Paulino, let's wait for the mic.
I think the publication of the EMPAREC study when empagliflozin, even the name is very difficult, was kind of disruptive in the sense that compared to placebo, this new class of medications, whereas sodium glucose cotransporter inhibitors reduce the primary endpoint of death, myocardial infarction, and stroke, but the main component was reducing death. So what is your opinion, and if you're including this drug in your current treatments for patients with high cardiovascular risk and diabetes type 2?
Sure. Primarily, I have not jumped onto this class of medications to look at patients to improve their cardiovascular outcomes yet. I would rather wait to get some more information with some more studies that are yet to come out. However, the medications have been promising and certain that I have seen some weight loss with these medications. I'm a little concerned about genital infections, more so in women as compared to men. I asked them to be more cautious about it. Another side effect which I have not listed up here, but they have noted, so though not approved for type 1 diabetes, some practitioners have used this medication for type 1 diabetes, wherein they noted that these patients went into DKA. Why? Because once these medications were started, the excess glucose load was reduced with glucose being rendered out in the urine, and they had required lower insulin, which caused a relative insulin deficiency. So they have seen this largely with type 1, but they have not excluded this with type 2 diabetics. So yes, I'm a little picky in choosing this drug of medications in all of my patients, but yes, it does have some favorable outcomes.
Well, thank you for covering, my goodness, an extensive amount of information. I have to say also I was ophthalmologically challenged seeing some of these slides. So that would be a suggestion for you down the line, and maybe pare it down pare it down for the non-endocrine audience as to what are some of the take-home messages. And I have questions along these lines. One is, I see through our patients, obviously we're not managing these diabetics because the field is getting even more complex than we can even handle. So the question number one is, I see at times recommendations indirectly through patients that some endocrinologists are happy with hemoglobin A1C in the 7.5, almost 8 range, okay? So the question, at least in cardiology, we have some risk factor calculators, right? And the question is, within a profile of a certain individual, knowing some of the disadvantages at times of tight control, is how do you, as a cardiologist, be happy or anxious regarding a control of diabetes, knowing that they have cardiovascular disease? That's one. There are so many classes of agents, so that's the question number two. So many classes of agents. Is the recommendations currently to try everything that is non-insulin and get to insulin when everything fails? Because we see patients on 3, 4 at times, drugs, 5 drugs. Try to ignore that personally because I have no idea what the algorithm is to help these individuals. So if you could address these two, I think it would be fine.
Sure. So the answer to your first question, yes, I think we are still at a loss in terms of having some clear-cut information in regards to how low should one go for a patient. In my practice, what I try to do is, if I have a young patient who's a brand new diabetic, 35-year-old gentleman, overweight or obesity, newly diagnosed diabetes, yes, I will get aggressive in these patients. I will, my first choice in such, depending on how severe their glycemia is, I would go with insulin or metformin initially. That is the first thing I would look at. I will consider adding agents like DPP-4 inhibitors and GLP-1s, primarily because they have seen, if you would have come up to the grand rounds, medicine grand rounds last week, if you may have heard of Dr. Ralph DeFranzo. He's a well-known, well-renowned diabetologist from San Antonio. He has done extensive work in this matter. I'm not saying that I follow his plan, but he gave some good points in the sense that his plan was, he looks at metformin, he looks at TZDs, GLP-1s or DPP-4 inhibitors, and more recently, in terms of some recent favorable outcomes with SGLT2 inhibitors, has shown some benefit there. Insulin has been relatively neutral in terms of looking at the long-term cardiovascular risk of patients.
I mean, is there some recommendations from the diabetic associations, endocrine associations? Because what you mentioned there is less than 6.5% or greater than 6. Where's the threshold that is high threshold, meaning below which you should drive?
Yeah.
And I haven't seen that.
Yeah. So if patients have established complications, if they have retinopathy, if they have microvascular disease, macrovascular disease, they are on dialysis, I tend to be a little bit liberal. I will look for around 7.5 A1C as my goal. Push comes to shove, if they are less than 8, I'm relatively okay, depending on what's their risk of hypoglycemia, what is their ability to cope with hypoglycemia. Hypoglycemia unawareness is a well-known problem in patients who are intensively treated. So based on these parameters, if there are complications, I would range around 7.5 to 8.
Are the data solid regarding that if we have tight control, the excess mortality is indeed from hypoglycemic events? You see what I mean? I mean,
right.
It may be non-causal, but we just want to have a feel for it.
True. Sure. There's a perception that the excess mortality could be associated with hypoglycemia, especially if you look at a cohort study and these studies, they had noted patients who already had some form of macro or cardiovascular disease, and they included such patients. So we don't know for sure in patients who already have existing complications how low is beneficial. And is hypoglycemia? Yes, hypoglycemia is a serious concern for patients treated with diabetes. That's my first goal. 1, prevent hypoglycemia. 2, then correct hyperglycemia. That's how I approach a diabetic patient. what sources or what resources do they have to resort to if in case they were hypoglycemic? Does it occur while they're driving? Do they know if the glucose is down to 30s? Or they go shaky if it's 70s? So all these factors help me understand that. And that's how but yeah, if they're already an existing disease, I don't go too tight, at least yet.